Most people first hear about type 2 diabetes when a blood test changes. A fasting glucose comes back high, HbA1c crosses a threshold, or a doctor says the word out loud. But the biology usually starts earlier than that, often long before type 2 diabetes becomes obvious on routine tests. The body has already been working harder to keep glucose under control. That earlier phase matters. It is where insulin resistance, pancreatic compensation, and changing glucose regulation begin to form a pattern. This video is for two kinds of viewers at the same time. If you are not medical, I want the process to make sense without needing a textbook. If you are a medical student or a healthcare professional, I want the structure to feel familiar. General definition, clinical significance, pathogenesis, pathophysiology, symptoms, clinical course, diagnosis, outcomes, and treatment. So we will keep the language clear, but we will not remove the medical backbone. Let's start with the basic definition. Type 2 diabetes is a chronic metabolic disease in which the body has difficulty maintaining blood glucose within the normal range. The central features are insulin resistance and, over time, insufficient beta cell compensation. In everyday language, the body still has insulin, especially early on, but many tissues do not respond to it as well as they should. The pancreas tries to make up for that by producing more insulin. For a while, that compensation can work. Later, if the pancreas cannot keep up with the demand, blood glucose begins to rise more clearly. That is the short version, but it leaves out why this disease matters so much. Type 2 diabetes is common, and its importance goes far beyond glucose numbers. Chronically elevated glucose is associated with damage to blood vessels and nerves. Over time, it can increase the risk of cardiovascular disease, chronic kidney disease, retinopathy, neuropathy, poor wound healing, and fatty liver disease. It also travels with other metabolic risk factors in many patients: central obesity, high blood pressure, high triglycerides, low HDL cholesterol, and insulin resistance. That is why type 2 diabetes is not only an endocrinology topic. It touches cardiology, nephrology, ophthalmology, neurology, hepatology, surgery, primary care, and public health. For medical students, it is one of those diseases where physiology becomes clinical very quickly. To understand the disease, we first need the normal physiology. After a meal, carbohydrates are digested into glucose. Glucose is absorbed from the gut and enters the bloodstream. As blood glucose rises, beta cells in the pancreas detect that change and release insulin. Insulin is usually described as a hormone that lowers blood sugar. That is true, but it is a little too narrow. Insulin is better understood as a signal of energy availability. It tells the body that fuel has arrived and that glucose should be moved into the right places. In skeletal muscle and adipose tissue, insulin binds to insulin receptors on the cell surface. That binding starts an intracellular signaling cascade. One important result is that GLUT4 transporters move to the cell membrane. GLUT4 is a glucose transporter. For a simple visual, think of GLUT4 as a doorway that allows glucose to enter the cell. When insulin signaling works well, more GLUT4 doorways appear on the surface. Glucose moves from the blood into the cell, where it can be used for energy or stored. Skeletal muscle is especially important because it is one of the major sites of post-meal glucose uptake. When muscle is insulin sensitive, it helps clear glucose from the bloodstream efficiently. The liver works differently. During fasting, the liver releases glucose to help maintain a steady energy supply. After a meal, glucose is already entering from the gut, so insulin signals the liver to reduce its own glucose production. A healthy post-meal response is coordinated. Glucose rises after eating. Insulin rises in response. Muscle and fat tissue increase glucose uptake. The liver reduces glucose output, then blood glucose gradually returns toward baseline. That is the system when the insulin signal is being heard clearly. Now let's move into pathogenesis. Why does type 2 diabetes develop? There is rarely one single cause. The risk usually comes from a combination of genetic susceptibility, age, body fat distribution, physical inactivity, nutrition patterns, sleep, stress biology, medications, and other metabolic conditions. Visceral adiposity is especially important. Fat stored around abdominal organs is metabolically active. It is associated with low-grade inflammation. altered adipokine signaling, increased free fatty acid flux, and hepatic fat accumulation. These changes can make insulin signaling less effective in muscle, liver, and adipose tissue. Family history also matters. Some people have a stronger genetic tendency toward insulin resistance, beta cell dysfunction, or both. Age increases risk because insulin sensitivity and beta cell reserve can change over time. Physical inactivity also plays a role because skeletal muscle is a major site of glucose disposal, and active muscle improves glucose uptake. Sleep deprivation, chronic stress, certain medications, endocrine disorders, and conditions like polycystic ovary syndrome can also contribute in some patients. The important point is that type 2 diabetes is not a simple failure of willpower. It is a metabolic disease with biological, genetic, behavioral, environmental, and social contributors. Those factors come together and create the setting for insulin resistance. Now let's look at the pathophysiology. In insulin resistance, the insulin signal is still being sent, but the tissue response is weaker. The pancreas may release insulin. The insulin may reach muscle, fat tissue, and liver, but those tissues do not respond as strongly as they should. For a medical student, this is the core idea. Insulin resistance means a reduced biological response to insulin in insulin-sensitive tissues. In skeletal muscle, insulin resistance can reduce glucose uptake. The insulin signal does not bring as many GLUT4 transporters to the surface, so less glucose moves into the cell after a meal. In adipose tissue, altered insulin signaling can affect how energy is stored and released. In the liver, insulin resistance can be especially important. Normally, insulin should suppress hepatic glucose production after a meal. When the liver becomes resistant to that signal, it may continue producing and releasing glucose when it should be slowing down. So the problem is bigger than one glucose value. It is a communication problem across several organs. The pancreas is sending a signal. Muscle and adipose tissue respond less efficiently. The liver may keep producing glucose at the wrong time. The bloodstream shows the combined result of those interactions. Early on, the body often tries to compensate. If the same amount of insulin produces a smaller effect, the pancreas can release more insulin. The goal is to keep glucose controlled despite weaker tissue response. This is called compensatory hyperinsulinemia. In simpler terms, the body uses more insulin to achieve a similar glucose result. That is why blood sugar can still look normal or only mildly changed during an early phase. The system may simply be working harder. A useful way to think about it is this: the glucose number is the visible result. The insulin demand is part of the hidden effort behind that result. Imagine two people leaving the lab with similar fasting glucose values. In one person, a moderate insulin response may be enough. Muscle takes up glucose efficiently, the liver reduces glucose output appropriately, and the system returns toward baseline without much strain. In another person, the same glucose value may require a much higher insulin response. The pancreas has to push harder, the tissues respond less clearly, and the liver may continue releasing more glucose than it should. On paper, the glucose value may look similar. Inside the body, the metabolic cost may be different. Over time, beta cell compensation can begin to fail. Beta cells are not passive. They adapt to increased insulin demand for a while, but if insulin resistance persists, beta cell workload remains high. In susceptible people, beta cell function may gradually decline. When insulin secretion can no longer match the degree of insulin resistance, glucose begins to rise. Often, post-meal glucose rises first. The body takes longer to bring glucose back down after eating. Later, fasting glucose may increase. HbA1c may rise as average glucose increases over time. That is how the hidden metabolic strain becomes visible in routine testing. Now let's talk about symptoms. A difficult part of type 2 diabetes is that early disease can be quiet. Many people have no obvious symptoms at first. That is why screening matters in people at risk. When symptoms do appear, they are often related to hyperglycemia. Classic symptoms include increased urination, increased thirst, increased hunger, fatigue, blurred vision, and sometimes unexplained weight loss. Some patients may notice recurrent infections, slow wound healing, or tingling and numbness in the hands or feet, but these symptoms are not specific. Fatigue, cravings, weight gain, or abdominal fat do not prove insulin resistance or diabetes. They can happen for many reasons. In the right clinical context, however, they may become part of a broader metabolic picture. Acanthosis nigricans is worth mentioning for medical learners. It appears as darker, thicker, velvety skin, often around the neck or skin folds. It can be associated with insulin resistance, although it is not diagnostic by itself. So the symptom pattern ranges from silent disease to classic hyperglycemic symptoms. That is one reason type 2 diabetes is often detected through labs rather than symptoms alone. Now let's look at the clinical course. Type 2 diabetes usually develops gradually. A simplified course looks like this. First, insulin resistance increases. Then the pancreas compensates with higher insulin secretion. For a while, glucose may remain normal or near normal. As compensation becomes less effective, post-meal glucose may rise. Then fasting glucose may rise. HbA1c may move into the prediabetes range and later the diabetes range. This is not the same in every patient. Some people progress slowly. Some remain in a prediabetes range for years. Some improve with weight loss, physical activity, medical treatment, or changes in other risk factors. Others progress despite efforts, especially if beta cell dysfunction is significant. The course is individual, but the pattern is recognizable. Insulin resistance creates more demand. The pancreas compensates. Compensation may eventually become insufficient. Glucose abnormalities become more visible. Now we need the diagnostic framework. For medical learners, this is the checkpoint. Glucose status is commonly classified using HbA1c, fasting plasma glucose, or a 2-hour oral glucose tolerance test. With HbA1c, a normal value is below 5.7%. Prediabetes is 5.7 to 6.4%. Diabetes is 6.5% or higher. With fasting plasma glucose, a normal value is below 100 milligrams per deciliter, or below 5.6 millimoles per liter. Prediabetes is 100 to 125 milligrams per deciliter, or 5.6 to 6.9 millimoles per liter. Diabetes is 126 milligrams per deciliter, or 7.0 millimoles per liter, or higher. With a 75-gram oral glucose tolerance test, the 2-hour plasma glucose value is normally below 140 milligrams per deciliter, or below 7.8 millimoles per liter. Prediabetes is 140 to 199 milligrams per deciliter, or 7.8 to 11.0 millimoles per liter. Diabetes is 200 milligrams per deciliter, or 11.1 millimoles per liter or higher. A random plasma glucose of 200 milligrams per deciliter, or 11.1 millimoles per liter or higher, can also support the diagnosis of diabetes when classic symptoms of hyperglycemia are present. When there is no clear hyperglycemic crisis or unequivocal hyperglycemia, abnormal results usually need confirmation. These thresholds matter because they give clinicians a shared language. They help classify normal glucose regulation, prediabetes, and diabetes. Still, diagnosis is more than reading a number in isolation. The clinical context matters. A doctor also thinks about symptoms, risk factors, medications, pregnancy status, other endocrine disorders, kidney disease, liver disease, anemia, hemoglobin variants, and anything else that might affect interpretation. HbA1c is useful, but it is not perfect. Conditions that affect red blood cell turnover can make HbA1c less reliable. Fasting glucose gives a single point in time. OGTT is more dynamic and can reveal impaired glucose handling after a glucose load. Each test gives a different angle on the same system. Now we can talk about outcomes. The good news is that type 2 diabetes is treatable. Prediabetes does not inevitably become diabetes. In some people, glucose regulation can improve significantly with weight loss, increased physical activity, better sleep, dietary changes, and treatment of contributing conditions. In type 2 diabetes, good care can reduce the risk of complications. The concern is what happens when hyperglycemia and associated metabolic risk factors remain uncontrolled over time. Small blood vessels can be damaged, leading to retinopathy, Nephropathy and neuropathy. Large blood vessels are also affected, increasing the risk of coronary artery disease, stroke, and peripheral arterial disease. Kidney disease, fatty liver disease, infections, poor wound healing, and neuropathic pain can also become part of the long-term picture. This is why treatment is not only about lowering glucose, it is also about reducing cardiovascular risk, protecting kidneys, preventing complications, and improving quality of life. Now let's briefly cover treatment. This is not a personal treatment plan, and it cannot replace medical care, but for the disease framework, medical students should understand the main pillars. The first pillar is lifestyle intervention. That includes nutrition, physical activity, weight management when appropriate, sleep, smoking cessation, and reducing sedentary time. Even modest weight loss can improve insulin sensitivity in many patients. Physical activity helps because contracting muscle can take up glucose more effectively, and regular exercise improves metabolic flexibility. Resistance training is also valuable because muscle mass plays an important role in glucose disposal. The second pillar is cardiovascular risk management. Blood pressure, lipids, kidney function, smoking status, and overall cardiovascular risk matter in type 2 diabetes. This is why diabetes care often includes statins, antihypertensive therapy, kidney protective strategies, and regular screening for complications when appropriate. The third pillar is glucose-lowering medication. Metformin has traditionally been a common first-line medication for many people with type 2 diabetes, especially when there are no contraindications. It mainly reduces hepatic glucose production and can improve insulin sensitivity. In recent years, treatment has become more individualized. GLP-1 receptor agonists and dual incretin-based therapies can improve glucose control, support weight loss in many patients, and may provide cardiovascular benefit in selected groups. SGLT2 inhibitors lower glucose by increasing urinary glucose excretion and can provide important heart and kidney benefits in patients with certain cardiovascular, heart failure, or chronic kidney disease profiles. Other medication classes may also be used depending on the person. DPP-4 inhibitors, sulfonylureas, thiazolidinediones, insulin, and others. The choice depends on many factors: HbA1c level, weight goals, cardiovascular disease, heart failure, kidney disease, cost, side effects, hypoglycemia risk, patient preference, pregnancy considerations, and the overall clinical picture. Some patients with type 2 diabetes eventually need insulin, especially when beta cell function declines or when glucose is very high. That should not be framed as a personal failure. It is sometimes part of the natural history of the disease. The treatment goal is not simply to force a number down. The real goal is to reduce risk, protect organs, support long-term health, and make the plan sustainable for the person living with the condition. Now let's bring the whole pattern together. Type 2 diabetes is best understood as a system-level process. Blood glucose is the visible part, but underneath it are insulin signaling, pancreatic workload, liver glucose output, muscle glucose uptake, fat storage, inflammation, genetics, environment, and time. The process often begins with insulin resistance. The pancreas compensates by producing more insulin. For a while, glucose may stay close to normal. Later, compensation may become insufficient. Post-meal glucose rises, fasting glucose rises, HbA1c rises, and the clinical categories become visible. Symptoms may be absent early, which is why risk-based testing matters. Diagnosis uses defined glucose and HbA1c thresholds. Treatment combines lifestyle, cardiovascular risk reduction, and individualized medication. The main idea is simple enough to remember. Type 2 diabetes develops when the body can no longer maintain glucose balance against the background of insulin resistance and progressive beta cell strain. That does not make the process hopeless, it makes it understandable. And when a process is understandable, it can be recognized earlier, explained more clearly, and treated more thoughtfully. Patterns are how the body speaks over time. Our job is to learn how to listen carefully, without fear and without oversimplifying the story. This video is educational only and does not replace medical advice. If you are concerned about your blood sugar, insulin resistance, or diabetes risk, speak with a qualified healthcare professional. Follow the body pattern for more clear, medically grounded explanations of the hidden patterns inside the human body.